I've got a horrible feeling that I'm going to learn a lot more from you lot than you're going to learn from me in today's course, but I'll do my best. That's our new super hospital, very expensive PFI. Some people call it the three potties. So I suppose when we're looking at manipulation of people's coagulation, I mean, we know generally people sit somewhere on a spectrum of coagulability. Some people have got thin blood, some people have got sticky blood. We obviously manipulate that pharmacologically. And the devil is the cardiologist, because cardiologists are not satisfied, in my mind, until they absolutely stop someone being able to form a clot at all, so they can keep their stents nice and pristine. So the cardiologists are the devils, and they've got these patients on. I mean, why give one antiplatelet agent when you can give two? And if you're on two, why not add in another one? And so there's a little bit of that sort of creep going on. And with these new oral anticoagulants, we'll probably find a lot more patients go on antiplatelet agents in combination with them. But as surgeons and anaesthetists who need to operate on someone and hopefully stop them bleeding so we don't have to give them blood and make them ill, we need to correct that abnormality. And I put an little angel, I don't know if that's a haematologist, probably not. So we're going to look specifically at antiplatelet agents and management peri-operatively. Now, I just want to reassure you that nobody really understands platelets. Okay, there are about 3 people in the world who sort of vaguely understand them. I work with one of them. And, you know, it's a very complex organelle, but I'll break down into platelet agents that some of you will be familiar with, a few that maybe you've not used. There's a few that I've never used. We'll look at aspirin, which is a COX-1 inhibitor. The drugs that I'm going to focus on a lot, because they're obviously in clinical use and in increasing use, are the P2Y12 inhibitors. So they inhibit this P2Y12 ADP receptor. Most of them compete with ADP, although there is ticagrelor that indirectly inhibits that receptor. I'm not going to say any more about dipyridamole. On its own, it's not that much better than spud water, and it's reversible, and you just need to give the last dose the day before surgery. So I'm not going to say any more about dipyridamole. There's a new antiplatelet agent. I've never used this one. I don't know how many of you are familiar. I'm going to mention about that one. And I'm not really going to talk about these GP2B3A inhibitors. They're all given parenterally. They all have very short half-lives. They're probably not going to be applicable to cardiac surgery, although I have seen papers where they've used this for bridging therapy, given intravenous anti-2B3A platelet inhibitors, just to bridge someone after they've stopped their antiplatelet agents and then had their surgery. But I'm not going to say any more about those, but we can talk about them in the end if you're interested. I think aspirin's probably one of the easier ones to talk about in some ways. Very short half-life. It's metabolized quite quickly to relatively inactive components. If you look at meta-analysis of all surgeries and taking aspirin before those surgeries, it increases the bleeding complications by a factor of about 1.5, not a lot really. It is irreversible, and we know that platelet recovery occurs about 10 to 15% of your platelets will be replaced each day. So if you extrapolate that, it's going to take about 7 to 10 days for fresh platelets that have not been exposed to an irreversible drug to replace that platelet mass. And that's where a lot of the advice comes about irreversible platelet inhibitors and stopping for 7 days. I don't think aspirin's that simple, actually. And there's some interesting in vitro experiments that I think reflect what we see in vivo. And it doesn't take a lot of platelets to reverse the abnormality. So if you look in vitro, if you actually do light transmission aggregometry with platelets, you only need to add a small amount, 30% of normal platelets, to actually correct that aggregometry. And it actually differs from the P2Y12 agents that we'll look at later. And the defect does appear to correct a lot quicker than you'd anticipate for an irreversible inhibitor. And I think this reflects the nature of aspirin and the fact there are bypassing mechanisms around this COX-1 inhibition. So aspirin, you don't need to stop it for 7 days. In fact, do you need to stop it at all? So I've just gone for the most recent guidance, the ACCP guidance. It's considered authoritative. And they are now saying that in patients receiving aspirin, who require coronary artery bypass surgery, then we suggest continuing aspirin and not stopping it, as perhaps has been done in the past. I mean, obviously, if someone's on aspirin for no good reason, there's no reason to stop it. But if someone's on aspirin and they actually should be on it, the advice is carry on and accept that there may be a small increased risk of bleeding. And there are a couple of papers I've highlighted that are quite interesting. The Aspirin one was actually a randomized study where they gave people aspirin or placebo. I mean, they did struggle to recruit, but they did have over 200 in each arm, I think. And it actually showed that peri-operative aspirin reduces the absolute risk of major adverse cardiac events, but an absolute reduction of 7.2%, quite a lot. And with no increased bleeding complications, although it wasn't powered to look for bleeding complications. And the other study was actually observational, the KOTL, and again showing that if aspirin was given within 5 days pre-op, there was reduced mortality, less renal failure, and a shorter hospital stay. So I think aspirin, unless you disagree with that, it'd be interesting to see. You don't stop it, and taking it pre-op is probably favourable. So moving on to the P2Y12 receptor antagonist. So clopidogrel is the one that we're all familiar with. It has to be metabolized through 2 steps, and this is one of the reasons that clopidogrel is a bit complex. Because of natural genetic variations in cytochrome enzymes, we find that there's a huge variation in the potency of clopidogrel between individuals. Prasugrel is a sort of second generation, has a similar effect. It sort of competes at the same receptor site, but it isn't quite as subject to cytochrome P450 enzymes. So if you give it, you're more likely to get platelet inhibition, whereas if you give clopidogrel, there's a little bit more variance. Ticagrelor works in a slightly different way, on the same receptor, but not directly competing with ADP, and it is reversible, these two being irreversible inhibitors. So this is just to show that if you use this is light transmission aggregometry, this is patients taking either black 300, white 600, milligrams of clopidogrel, you get quite a variance in platelet inhibition in an in vitro test in the population. And it is said that 30% of clopidogrel-treated patients are actually resistant. Clinically, it doesn't look like that. I mean, if you put people on clopidogrel with stents, about 2% of them thrombose a year. So we're not seeing 30% of people's stents thrombosing. So the translation from laboratory to clinical is not that clear. And you may say, well, if clopidogrel is that variable in the population, why are we using it? Why aren't we using prasugrel or ticagrelor? And the reason is pretty straightforward, really. Clopidogrel is generic and it's cheap, and the other two are outrageously expensive. And if you've only got 2% thrombosis rate from stents, you just can't justify on health economics, although we can still outrageously justify adding on extra blood tests to blood stocks that don't actually help anybody. So peri-operative clopidogrel, I think everyone will generally accept that you will get increased blood loss. It's not absolutely predictable, but on the whole, patients will lose more blood. You have a higher risk of transfusion, you have a higher risk of re-exploration, and you don't actually, in any of those observational meta-analyses, show a difference in mortality rates. In terms of reversing the agents, if you remember what I mentioned about aspirin, it seems to be at about 3 days before the effects of aspirin are reversed in vitro. It does actually take about 10 days to reverse the effect of clopidogrel in vitro in losing light aggregometry. And as opposed to when you can spike with 30% platelets, you have to spike with 90% platelets to actually reverse that effect in vitro. So there is a difference between those two irreversible agents. A 30% correction is probably equivalent to about 1 adult unit of platelets. A 90% correction is equivalent to at least 3 units of platelets in vivo, and that's just a rough sort of on the back of an envelope calculation. And it does mirror that in the fact that the bleeding time, we don't do bleeding times these days, but the bleeding time where you just make a nick and see how long it takes to stop, it doesn't really normalize until about day 8. So it is a different kettle of fish than aspirin. And moving on to prasugrel, we're getting even more potency. So we're getting, it's like clopidogrel plus. And I don't even know how you pronounce it. I don't know if it's Scylla, Charybdis, or I'm not a scholar, I'm afraid. But essentially, it's between a rock and a hard place. If you go for prasugrel, you get more anti-platelet action, but you get more bleeding. So from this Triton study that actually did recruit quite a few sort of real-world patients, for every cardiovascular event you prevented, you got an extra hemorrhagic death. So you're getting more potency, but at a cost. And if you look at major and minor bleeding from CABG, you are actually getting more bleeding with Prasugrel. So what they looked at was a dose within 3 days, you got a 26% major plus minor bleeding. I mean, I'm not going to go into the definitions, it's just the comparison really, as opposed to 5% with Clopidogrel. And if you received a dose slightly longer than that, between 4 and 7 days, you get less bleeding, but you still got that discrepancy between Prasugrel and Clopidogrel. And this is what I think we're going to be potentially facing in the future, more potent antiplatelet agents. So going back to ACCP guidance, being the most recent, in patients who are receiving dual antiplatelet drug therapy who require coronary artery bypass surgery, we suggest continuing aspirin, but stopping Clopidogrel or Prasugrel 5 days before surgery instead of continuing. And I think that's a fairly reasonable suggestion. It says 5 rather than 7 because I don't know how many surgeons are patient enough to wait 7 days, let alone 5. But there is evidence, and I've just quoted one paper, that actually you don't have to wait till you've got complete normalisation of platelets. You can go in at some intermediate stage where you've got partial recovery, but you are going to probably need more platelet transfusions compared to those patients who are not exposed to that drug. This is just ticagrelor's behaviour. This is again in vitro light transmission aggregometry. So this is Clopidogrel. You start it. It actually takes a while for the effect of Clopidogrel to build up. Ticagrelor has a more profound effect and a more potent effect. If you then stop the drug, you get a faster tail off of ticagrelor as opposed to a more slow tail off with the Clopidogrel. So you get a rapid onset of action, a quicker reversal. Although if you do look at the hours, although it is a drug with a half-life of 10 hours, the actual effect of ticagrelor seems to last about 24 to 48 hours at least. So you just have to be mindful of the fact that even with ticagrelor, the reversible agent, you're probably going to be looking at a minimum of 48 hours after the drug if you want it to be out of the system, and it is a potent drug. But not as long as with Clopidogrel, or certainly not with Prasugrel. So I suppose in some ways it would be a favourable drug if you're a cardiac surgeon because you haven't got to wait quite so long, and hopefully you won't need to give platelets because it will have reversed itself. I'm going to sort of whiz, this is just another drug which actually there's some data that shows that it's superior to aspirin for treatment of stroke. I don't know whether it's going to become more heavily used out there. It seems to have a lot of side effects. It has a half-life of 12 hours and appears to be reversible, but I can find virtually no data out there about when to stop it and how long the platelet effects work. And I've never used this stuff, so I'm going to move on. I suppose one of the interesting questions is, can you, by platelet function testing, determine which patients have still got potent antiplatelet activity when you've stopped the drug? And you can say, can you safely go ahead with surgery? Should you be pre-booking platelets? I'm aware of lots of people using these sorts of point of care tests, and there are a lot of them out there. The problem, I suppose, the traditional way that we do it in Birmingham is you just put the knife in the skin, and if it starts to ooze, I suppose there's still a platelet effect there. But can we go back from that and actually, look to see whether there's some sign of a platelet effect that you can use for clinical determination of bleeding risk? The literature is not that supportive. I think people's personal experience, everyone seems very positive about their platelet testing locally, but the actual literature is not that great. I mean, this is just using, this is just with aspirin. This is using different platelet function tests to determine whether there's aspirin resistance. It's completely unhelpful. And this is with Clopidogrel. So what you're looking at is giving Clopidogrel to somebody and then testing platelet function. You're using, these are all different methods of point of care tests. You get a complete spread of results when you give a patient this Clopidogrel. Some of that's down to that genetic variability. Some of it's down to probably the methodology as well. How can you pick out patients that are or aren't going to bleed? Does it actually work? If you divide these into sort of high responders and low responders, does it predict bleeding? I know it's a busy slide, but the answer is, certainly in this study, no. So this is again using lots of different methods. What they did is they divided people up into quartiles of high response or low response, and you just don't see any difference in the odds ratio for bleeding at all. So on the face of it, the literature suggests that these point of care tests are not that great at picking out patients who have had antiplatelet agents that have been stopped, who may or may not bleed. But I do think that, I think this is something that I say, there seems to be this discrepancy between literature and what people are actually doing. So I'd be quite interested to know actually what people's experience is, really. And I've finished on that slide just in case anyone wants to ask anything more about those agents. Thank you.
Thanks very much, Will.
I mean, I know you use platelet mapping, don't you?
Yes, we do.
Yeah.
Quite successfully, I hope.
Yeah.
Are there any questions from the audience?
I'll ask a question. Gavin Murphy from Bristol.
You need to put the switch on.
Oh, sorry. Gavin Murphy from Bristol. I don't want to be too controversial. In my clinical practice, we don't stop clopidogrel, and we don't have an awful lot of bleeding. Admittedly, we do off-pump grafts. When we look at this, the point of care data that you just shown us, we're actually measuring aggregometry with and the effect of clopidogrel. It doesn't actually predict bleeding. And then I look at the actual data for clopidogrel and its efficacy in unstable ischemic heart disease, and these are all industry-sponsored studies. Mm-hmm. And I just am very skeptical about how good clopidogrel was 5 years ago and how not good it is now with new industry-sponsored studies that are evaluating new anti-platelet agents. Do you have any comment on that?
I think most drugs that we give to people are of doubtful benefit, actually, in reality. I think clopidogrel is just one of those. I think the number needed to treat is absolutely ginormous. I mean, I think the question will be answered better with the potent agents, because you will know that they are definitely inhibiting platelets, where clopidogrel, you've got the whole spectrum of efficacy. So I guess the data on the new agents is going to be interesting. I mean, there is a suggestion, that the more potent the agent is, it does seem to give you slight gain in terms of reducing thrombotic events. But as I say, at a cost, which is almost an equipoise for bleeding. So, yeah, I don't think I've answered your question, but...
Are there any other questions from the audience? Yep.
Just a practical problem that when clopidogrel is given inappropriately, which nowadays is in about 2/3 of acute aortic dissections, because they are treated like acute coronaries until someone wakes up and realizes they're not. It usually takes 12 hours for that to happen. That's when, from the surgical point of view, we need all the help we can get from people like you.
Yeah. I mean, because the half-life of clopidogrel is about 8 hours. So if you give a platelet if you've only just given, if you've given they give them a 300 milligram dose, don't they? I mean, if you've given a dose like that, if you then transfuse the platelets immediately, they will get inhibited. But I would still do it. I'd still give it. But what I always say is give platelets at the time of major bleeding, but then don't forget to give them again 24 hours later. Because then the drug is gone. Basically, the drug is gone then, so you know that your platelet transfusion will then be effective. So I do take that dual approach. This is only for the major bleeders. Yeah.
Okay. Well, I'll make a comment and then ask one question, which I've always found difficult to answer. We use multiplate. We've developed a protocol by which we identify people who are either responders or non-responders that will drive clinicians into being allowed to order platelets. They're not allowed to transfuse them. They have to wait until there's some clinical bleeding. That seems, in our database, to have shown a very marked reduction in platelet transfusion. Because beforehand, everybody was going, oh my God, they were aspirin clopidogrel, ordering 2 pools of platelets and then giving them whether people were bleeding or not, which is not how I think you should work. Yeah. Whether it's a good way or not. But the one question I'd have is, how many pools of platelets should you give? Is it 1 unit in weight? Is it 2 units in weight?
I mean, it's a really difficult question to answer, but I can tell you that we have patients with platelet disorders who have surgical procedures. I've got the benefit of working with a colleague who's incredibly conservative. He's quite a senior colleague. And I've learned that you can generally get away with giving 1 bag of platelets to patients with platelet disorders, and they generally get through most types of surgery. The problem is that this is a different, coming off bypass and cardiac surgery is a whole different ballgame. So I can understand why people might want to give 2. Giving 3 is almost replacing your platelet mass. But there isn't the data really to be absolutely certain.
So when you get rung up by an anaesthetist saying, I've got this patient on Prasugrel and aspirin.
Yeah.
I want 2 pools of platelets.
Yeah.
What do you say to them? Do you say, I'll give you 1 and I'll wait, or do you give 2?
Yeah, I mean, it depends on the clinical situation. It depends on the potential risk of underdosing with platelets. But we often do give 2, to be fair. But it's the timing. You know, it's making sure that you time your platelet transfusion as long after the dose of the drug as possible, really. I mean, if you give it immediately after the clopidogrel, you can give 1, 2, 3. They'll all get inhibited. So, yeah.
One more question.
Thank you, Heyman Lacrasse from Wolverhampton. Just to sort of add a bit more to this discussion about how many platelets get ordered, I think this is a logistic issue. Birmingham is very privileged in being able to offer platelets within 15 minutes, and I know Gavin also had this luxury. I usually, if I order a pool of platelets, sometimes I may even need to wait 2 hours before I get those platelets. So sometimes as a surgeon you think, oh, should I order 1 or 2? You think, oh, I'll order 2 straight away. Yeah. But I think it's a logistic thing rather than
I'm sure there's an element of that. Yeah, I mean, I think if you've got, I mean, we're about to change, hopefully, we are going to change our protocol to have platelets on standby rather than pre-ordering and things, and so we'll probably go for the give 1, see what happens, and then you've got another one there spare just in case. We spend QE, we spend over £200,000 on platelets a year. Okay, we're using a lot of platelets at the moment.
Richard Williams, Liverpool. A colleague of mine was telling me the other day that you give platelets, but they don't actually start to work for about an hour.
Yeah.
And this was based on some ROTEM evidence that had been done in the military.
Yeah.
Would you agree with that?
I mean, it's very difficult. It's very difficult to measure it clinically. But certainly, again, going back to our patients with platelet disorders who come in with epistaxis, they often respond within that sort of 60-minute time frame. I mean, I've heard that said. I've heard people say about red cells as well. They need to adjust to being in the circulation and everything. Yeah, I'm not quite sure, but but before they give out oxygen and stuff.
Sorry, Axel, we're going to have to move on, otherwise.